Mike will share probably some information here as far as, maybe not so much the history, but why, the importance here. I know we've done this course, Changing the Culture, maybe 2 or 3 times for certain in Hanover, face to face. So this is a 2-day course where we have you'll meet Luke, our instructor, who'll talk about substance abuse, and we'll also have Bob Swanson about mental health issues. And you get a full 2 days with them and how to teach and to go back and use the materials. There's also the e-learning. Some of you have taken that, in order to get credit from our accreditors, and you want credit for this class and you're one of our instructors. I would encourage you to take that class. I think it's maybe 4 hours or something, and it goes over a whole lot of stuff as far as substance abuse and mental health that you would use to teach as you went back. So keep in mind. But this is a little bit different. I know there's the champions. This is some champions, so it might, and then LMCI has some different things here, but nonetheless, there are some folks here that are taking the class for the credit. So, in this, because we've been shut down and will continue to be shut down, you're going to get a truncated or abbreviated version with the 2 experts here. One, Luke will kick us off, but Luke has taught this class again with us for this may be your 4th time. Luke can help redesign some of the curriculum a little bit. Luke comes to us. He's from the area here in Maryland, director at a treatment facility here. A lot of knowledge, and I think you'll find his presentation in particular as it pertains to the brain to be very, very helpful. And then, of course, we also have Bob Swanson, who used to be former co-chair here of the IFTI, the fund, and does some other teaching for us through STP, I think, right? And he does the new contractor class as well. But Bob has a good, excellent personal story, but also does a lot of work in dealing with mental health issues as well. So I think you're going to get you got the two experts here, I believe, to help you, talk about the importance, not just, obviously in the construction industry, but also, in everybody's daily life. So with that, I just wanted to see if Mike, if you wanted to say anything. I know you got some stuff to talk about at the end, but before we turn it over to Luke, I don't know if you wanted to say anything.
Yeah, just a quick welcome to everyone. I'll be speaking at the end of the session, but thank you all for being here today as we continue to move Helping Hand forward. One of our greatest components that we have in doing so is changing the culture of construction. And the opportunity to have both Bob and Luke here today talk about the issues. We're basically right now, we're building the foundation of the Helping Hand initiative. And it's a lot of foundational things that we're doing, but having Bob and Luke be able to relate that to what our members and others are facing in their lives in dealing with substance use disorder and suicide prevention and suicide issues, I think really puts it all together. So I'd like to introduce Luke and bring him on. So thank you all for being here.
Thanks, Bob. My name is Luke. I am Director of Addiction Services at a local treatment facility called Tranquility Woods, and we're in Pasadena, Maryland. Always enjoy doing these classes. But before I get started, would Alice or Nicole let me know of a hard stop time, so that way I know when I should stop for sure time-wise?
Will do.
Say that again?
Yeah, for sure.
It's staticky. So I'm going to go until probably at least till 2. And then Nicole or Alice, please jump in. One thing I do want to say that with COVID, I've been very familiar with doing groups and educational classes for 6 months now. One thing I do want to encourage, one thing that would help me is if I'm talking to a group of people, I do like interaction. So while I'm going on, I encourage people to unmute themselves if you have a question. Don't be shy or bashful to, while I'm talking, if you got a question, please speak up. I also encourage for me to see your faces. It is really hard to do a group if I don't see someone's face. It's like me, if like I was in front of you and you guys had a mask and I couldn't see you and see facial expressions. So you certainly don't have to, but I would love to see some faces, and most of you guys are doing that, so I appreciate that. What I'm going to do is share screen myself. So as I got introduced, my name is Luke, and I do work at a treatment facility, substance abuse dual diagnosis. So we deal with primarily mental health, but we also, it's kind of like peanut butter and jelly, and sometimes it's hard to decipher, or you can't do one without the other. Dual diagnosis and mental health. We're a small facility, 19 beds, and I think one thing we do really well is holistic. And what I mean by holistic is, yeah, we're talking about substance use, but as you guys know, and we're dealing with champions, and Tom asked me to come on to help train the trainers and change the culture. It's not just one thing it's affected. So I think treatment with substance use and mental health, it affects all aspects of an individual. So it really should be treated that same way, and we're going to talk a lot about that. Let's get going. The two main focuses that I'm going to focus on are these two things. How is this brain affected with substance use? And when it comes to changing the culture of construction, that's quite a task. So to do so, we have to really gain some insight and knowledge, so that way we know how to best help a person that might be struggling, whether they want help or whether they're resistant to it, and they might not even see the adverse consequences of their use. But you guys, as trainers and champions, you guys can see some things and help people proactively. That can certainly help change the culture, but maybe even save a life. So we will focus on those two things. I'm going to have some pictures for you, but if someone could unmute, I don't know if anyone has ever heard that this addiction is a disease or a brain disease. So I'm curious from any of the people on board, what does that mean for this thing to be a brain disease? And I'd love to hear from any perspectives or thoughts on that. If this is a brain disease, what does that mean? Don't be bashful. There's 30 of you.
Means you lack the control.
Lacks control. Great perspective. Good. Any other thoughts on it being a disease?
Possible chemical imbalances.
Chemical imbalance. Good. Does anyone think that it's not a disease? I'm a person that just celebrated 14 years of sobriety this month. And when I was in treatment and they said this was a disease, that was a real head scratcher for me. And part of the reason why I struggled with that either fact or concept or philosophy was, I'm putting this substance into my body. How could this be a disease? Does anyone have that perspective? All right, well, let's see. And if you do, if you don't be bashful as we get going. One definition of a disease is a disorder of a structure or function that's not specifically a physical injury. So if we look at that definition, it's a disorder, right? It's not functioning properly. And when we use substances to the level that are abuse, we're going to find out exactly how that is a disease and how that affects the addict and people around them. We're going to focus on, there's this term called post-acute withdrawal syndrome. And that's just a fancy way of saying that there's a group of symptoms, which is a syndrome, that happens after the detox, after the acute withdrawal. There is belief that there's 75 to 95% of recovering alcoholics and addicts have some kind of brain dysfunction, that there's some kind of damage to the brain if you abuse substances. Part of the reason being that it affects the central nervous system, and it takes up to 2 years for that to heal. So now when we're talking about if there is brain damage from substance use, that is certainly going to affect people's work, people's relationships, and things like that. So let's see what we mean by that. Here's the brain, right? And one of the things that we're going to talk about at the end, there's all different kinds of treatment. And I think one of the struggles that we're seeing in all industries and all work environments is if people struggle, what kind of treatment do they really need to get the help to maintain sobriety, but also be appropriately functional in their relationships, appropriately functional at work, and also to prevent further relapse. Because a lot of people can get dry and stop using with help. I think the real struggle and why this is an epidemic or a pandemic, and I'm not talking about COVID, I'm talking about substance use, is really designing treatment so that way relapse doesn't continue. One of the things that the brain is affected, it's damaged from top to bottom. Okay, so you see 3 levels. You got the cerebral cortex, the midbrain, where the part of the hippocampus is in that primitive brain. And what happens when we use substances to the level of abuse? Let's use the example of alcohol, right? We've got this lovely organ called the liver, and the liver does over 500 vital functions that it does. But when we use substances, and one of the reasons why alcohol binge drinking is 4 to 5 drinks in a certain period of time is not just for throwing out a number, that medically when you consume 4 or 5 drinks, depending on your body weight and height, that your liver stops doing most of your vital functions. Now your liver does everything from produce bile so you can excrete waste from the body. It helps break down fats. It helps produce proteins for blood plasma. So the liver is very important. But when you introduce a toxin, and when you consume alcohol at a certain level and amount, and your liver can't break it down and metabolize it, it's got to go somewhere. So what happens is the liver says, I need to get rid of this poison out of the body, and it can't. It has too much. So then it breaks the blood-brain barrier and goes straight to the brain. So that's how alcohol works. Now, if we snort a substance, it's going to go straight to the brain. If we do IV, blood, straight to the brain, and it starts to literally damage and toxify the brain. So when you look at the word detox, it means remove toxins. Now, if people continue to use days, weeks, months, years, and decades, we're going to do a lot of damage to the brain. The tricky part is, it's our society, has adjusted for really accepting this, but our society accepts that, high blood pressure, will just take a medication. And if you got diabetes, don't change your diet or exercise, and you just take some insulin or things like that. So we often treat symptoms, but when we continue to damage this brain, it's got an issue. Look at that, it's all fancy. Don't say I did anything fancy for you. Look at that. All right, so I want to break down some of these symptoms of post-acute withdrawal. And look at it in the eyes of a trainer. There are the National Institute of Drug Abuse and Addiction, that there are statistics that say 1 out of 4 Americans will have a drug disorder in their lifetime. So whether it's you or someone that probably in your family, let alone at work, we've got 30 plus people here, that's someone's either in recovery or probably has a substance abuse issue themselves, if you look at it statistically. So look at this when it comes to being a trainer. Here are some of the symptoms when it comes to substance use. The inability to think clearly. So let me give you that doesn't mean that our IQ, we're not dumb, right? That it means that our rational logic part of our brain is damaged. Now, remember when we look at this brain, our brain is damaged top to bottom. So we have the cerebral cortex, and the cerebral cortex is responsible for rational logic and reasoning. When we use substances, that's the first part of the brain that we damage. So as loved ones or as coworkers, if you have someone abusing substances and this part of the logical part of the brain is damaged, often people that aren't actively using the substances are seeing these negative consequences first, right? So you as a coworker or a boss, that you may be seeing the behaviors of someone that's really struggling. And this is where rationalization and justification comes in for the addict or alcoholic. Right? That if I'm using a substance and someone's angry or frustrated with my work ethic, and I'm going to hide my substance use, and I'm going to use the part of the brain that is actually damaged. I'm going to justify, I'm going to use my rationalization why it's not as bad as you may think, right? And at this point in stage, we might not even be talking about substance use. We just might be talking about their ability to take criticism, or their ability to show up or do a structured task without messing up. But if this part of the brain is damaged, we're going to start manipulating and rationalizing our behavior. Does that make sense? So there's a statistic that says this is when in early recovery, right? When people are going through detox, that acute stage, that 7 to 10 to 7 to 14 days, the brain is contracting and expanding in the skull, trying to find its normal steady state. It's desperately trying to find a way to go, what is my normal amount of dopamine, the normal amount of chemicals that is my normal? But because we're introducing this very powerful chemical, it can't do that. So the brain is in flux, and it's trying to find out what is the norm. Now, when we talk about progression, there's this chemical, this feel-good chemical called dopamine. We have it naturally in our body. We release dopamine when we meet a goal, right? Or we're exercising, during sex, when we feel accomplished, when we're playing sports, dopamine is released. Now, dopamine is also released in a very powerful way, and I call it in a synthetic way when we take substances. So it's the pleasure center of the brain when dopamine is released. Chemically, it's part of the reason that your brain tells you to do it again. So when you introduce a substance and it's a feel good, for me, I'm in Baltimore, hey, the Orioles won, let's have a drink. Hey, the Orioles lost, let's go have a drink. Now, early on, that's just, it's part of my routine. But as I begin to rewire my brain and my circuits in my brain, it becomes the reward circuit, the pleasurable experience. This is one of the reasons why when you continue to use and you're releasing this dopamine, that sometimes it's not just a choice. When people have cravings, some people relate it to, I just can't have a pint of Ben and Jerry's in my freezer because I'm going to eat it all, that whole pint. Now imagine that times 10 or times 1,000 with this chemical release that's beginning to rewire the brain. This is also part of the brain that tells the brain to survive, and we're going to talk about that as well. For people that are in 12-step recovery, right, when we damage the cerebral cortex, the logical part of the brain, the inability to think clearly, 12-step recovery says it in slightly different terms. They say, step one, we admitted we were powerless over drugs and alcohol and that our lives had become unmanageable. So our ability to manage in a healthy way, we can no longer do it because of how the brain's affected. So I'm going to keep going, but I don't feel like talking to the whole hour. So if you got any questions, thoughts, whether it comes to people that you're in the job field with or anything, please jump in as we go along. Okay. So another symptom of post-acute withdrawal is memory problems. That is the second part of the brain, the midbrain, it's responsible for memory and emotions. Getting trigger happy over here. So what does that mean exactly? A lot of times people are on that emotional roller coaster. So we've got memory and emotional overreactions. When that middle part of the brain is damaged, that is part of the brain that is responsible for those two things. So how you begin to remember things, once again, we're taking on information, the logical, rational part of our brain tries to make sense of it, and then we store that with memory and emotions. You could also think at it as it in this way, that I have a thought, my boss tells me to do something, right? And I may have stress because I know I frustrated him before because I came in late or I didn't do it, I messed up the job and I got to redo it. And then all of a sudden, the emotional part really begins to kick up. Now, the issue is I'm beginning to train myself to cope with substances, right? So the emotional part of the brain, all of a sudden, those initial stresses that might be everyday stress can be more intense. So the whole make a mountain out of a molehill. So I hope we're beginning to see why to just put down a drink or a drug is not always that easy because of what it does to the brain, the disease, the disorder. I see it all the time. And one of the reasons why treatment is no longer just, getting off of substances for a lot of people, a residential setting where they're there for 1 to 2 months is really vital for a lot of people because their ability to not emotionally overreact takes quite a bit of time. To all of a sudden go through detox of 7 to 14 days and then go right back to work can be really challenging because we took away their go-to coping mechanism or one of their go-to coping mechanisms. And then they've got all these thoughts and emotions going on and they're trying to process and make sense of it, but they really can't. So I really believe, and I think it's great that the IFTI and working with Tom and the IUPAT, that we're really beginning to see the need to get help, change the culture, changing the norms. But I think the next step in this is really providing resources through the EAP of some really good programs that can allow these, our coworkers and our family members to seek the appropriate treatment. I relate it to this. If someone has heart surgery, right? Or if someone has heart surgery and they're on high blood pressure medication, a doctor is going to do more follow-up, right? So that's a physical structure where there's going to be physical therapy, but why else was this heart condition happening? Well, it might have been high blood pressure. It might be stress. It might not being able to cope with that. It might be unhealthy lifestyle. So what treatment should be for that heart condition is not just a surgery, right? So if you look at substance abuse, sometimes the surgery is detox. And that might be those 7 to 14 days of going to a detox facility and getting and tapering off so that way you don't have a heart attack or a seizure, and that way you don't have horrible withdrawals outside of that safe medical environment. But it shouldn't end there, right? So I hate that we have a model that there's just a detox facility and people can go right back to work because you're really not dealing with, to me, one of the major issues, and that is the 6 to 24 months of the brain, right? So if it can take up to 2 years for the logical thought process to come back, we really need to treat this holistically. So as champions, as trainers, one of the things that I really want to get across is, so whether people come right back or they're in an outpatient that we're going to talk about, that we really have to have the mindset of this is a person that is, he or she is probably scared. They might not know how to express the emotions. They may feel that, man, I was gone for 28 days. How many people know I was at a treatment facility? Is my boss going to be harder on me? Can I even function? Because part of the issue with the substance use is we got used as an addict functioning in a dysfunctional state. So one thing that I like to mention, when I went to inpatient treatment, I took a semester off school, right? That was the recommendation. I certainly didn't want to do it, but I did it. And then I went back to school, okay? This was about, I don't know, 3 months after I went to treatment. And I remember I had to read for the first time, and I had to write a paper, and I had to do a paper and a project. And I read that first page of that book, and it didn't absorb, right? So then I read it out loud, and I could not absorb the words that were on that page or that paragraph. So instantly my brain started going, and I thought, I need to be able to do this work. So guess what went up? The stress, right? I'm worried that I'm not going to be able to read this information so I can write this paper. So my ability to think, right? My logic at that time with 3 months sober is, I'm going to go down the hall. I'm going to buy Adderall from that guy that has it prescribed. I'm not going to snort it. I'm not going to smoke pot on it. I'm not going to drink on it. And even though it's not prescribed for me, I'm going to take that stimulant so I can do this work. That was my logic. What I know now is if I do that, all of a sudden that could have led to other substances that released a chemical change in my brain. Luckily, I didn't do that, right? I talked to my sponsor. I went to the meeting next door. He says, you got a meeting next right door. You can't do the paperwork anyway. Why don't you just go to a meeting and come back and see how you do? And an hour and a half, 2 hours later, all of a sudden my brain was in a different spot and I was able to do that paper. But for people that all of a sudden that didn't have to think about doing some of their jobs, second nature to them, whether it's, working under a car or working with fine motor skills, or you name it, whatever the field or job is, all of a sudden might not seem second nature anymore because their brain state is different. So whether you're doing stuff on computers, you're doing hands-on stuff, for some people, they were used to functioning in an altered state. And now that they're no longer have those chemicals in their body and their brain is beginning to go like this, and what is my norm, it can lead to a lot of stress. And all of a sudden they're thinking, oh my gosh, I can't live up to my expectations. I can't live up to my boss's expectations. And we don't often know how to deal with that stress and anxiety. So it can be really challenging, right? And that's one reason why relapse can be very, very high, no matter the field. So we're also going to talk about other forms of treatment after a detox, ever residential, called an intensive outpatient. There's a lot of outpatient facilities that after you do your daily routines, that from 6 to 9 o'clock at night, you go to a treatment facility and you do groups with people that are in the early part of their recovery, where all of a sudden they can talk and they go, man, I really struggled with work, things that I didn't have to think about before. I don't know if I can even do this job anymore. Right? And you're with a facilitator and other people in that early part of recovery to help with those transitions. That's so very important to increase the success rate, right? There's relapse prevention groups to help process these type of things, because remember, I used to be really good, I thought, functioning inebriated, intoxicated, coming up, coming down in an altered state. I took that away, and it can take my brain up to 2 years to function in a healthy way. So we as people in early recover can certainly make a mountain out of a molehill, and we can emotionally overreact. The other side is it could be just the opposite. It could be numbness. Any questions so far? Thoughts? Give me something.
Hey, Luke, this is Brian. I'm out of Western PA, but also I always thought it's on that note, it was always interesting how, like the addict in my life, how manipulative and almost genius they could be in active addiction. Mm-hmm. And then after detoxing, needed help with like the basic life skills. Mm-hmm. I always found that part interesting, how the brain will, like I said, they can be brilliant in active addiction. They can manipulate, they can talk people out of their money, how they'll steal things, but then once they get clean, they can't write a check. So.
Second that, yeah.
Yeah, it's amazing how the active addiction and that brain is in that brain state, that it literally becomes a survival type of mentality. So the thoughts, the emotions, the behaviors, the actions and reactions are designed to, how do I live my life so that way I continue my substances? And it's an obsession, it's a compulsion, and it's an addiction, right? So it becomes survival, 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 which can frustrate bosses and family members when they're starting to prioritize other things for the substance, because it begins to damage, right, the lower part of the brain, which is what we call the primitive brain. So the primitive brain is the lower part, right? So the primitive brain is responsible for things that you don't have to think about. It's heartbeat, it's breathing, it's blinking, it's breath, it's all those things, but it's also the part of the brain that's responsible for survival. So when you think of progression, often people think, I am not an addict because, I still want to work, or I'm not willing to sacrifice my family. But to your examples, you guys are talking about how the manipulation, and they're willing to risk things to continue to use really at any and all costs, right? And their justification, their rationalization, that's really the primitive brain at work, right? And eventually, as progression goes, all of a sudden the job, the family, the kids, the paying the bills and all that stuff goes too. But that primitive brain is affected a whole lot earlier than people think, right? That powerlessness, right? So looking, and once again, 12-step recoveries, we're seeing how, it's pro-con, right? How can someone choose? Well, eventually if it doesn't become a choice. And I say one part of the brain sells the BS, the other part of the addictive brain buys the BS, right? So we are, as an addict, just in that mode, right? So when we talk about that survival brain, that's when the family members can really be at wit's end. And these are where the boundaries for family members or bosses or coworkers, where it's, if you don't take this seriously, then we are going to have to fire you. Or, you've been absent 3 or 4 times, or you've been late, or you didn't pay those bills, or whatever it is, or you're stealing from the job, that we're going to have to let you go. And understandably so, those are boundaries that we have to do. One of the things that I hope to get across is how, as we as support members, as trainers, as loved ones, how can we prevent or set healthier boundaries before it gets to that, right? And we can't always do that. It's not always because it's their choice to get help, but part of, I think, changing the culture is, how can I be more informed? How can I see these things? And I'm going to use this word, how do I not be in denial for, I don't want it to wait till it gets to that before I need to set maybe a boundary, so that maybe they can get help or choose to get help a little bit earlier. That's the ideal. Doesn't always work that way, I know. So we're talking about, once again, all these physical coordination problems. Once again, after people stop using for those 7 to 14 days, people can struggle with balance, with coordination. They still may have tremors from use, depending on how much damage they've done to the central nervous system, which is the brain and spinal cord. They could have light sensitivity. They could have taste problems, headaches, balance issues, and that can last for a while. Now, we often see that with alcohol in people in their 40s to 60s, but I've seen people in their early 30s that have really struggling with physical coordination, the amount of damage they've done with substances to them. And we have stress and anxiety and sensitivity. I think that is one of the biggest reasons for continuing treatment outside of a detox, and continuing treatment for up to 2 years, is because the ability to cope with thoughts and emotions in a healthy way can take time, right? And we know people that aren't addicts and alcoholics that we work with, that they're that they have a hard time communicating, that they're not persons, they don't know how to take accountability. So we know that there are other people that don't have that aren't addicts and alcoholics that can have all these issues too. Now let's throw some substances on it, and it can be that much more challenging. The brain is damaged top to bottom. So logic and reasoning goes out the door. How we remember things, the emotional ability to cope with it goes out, and then the survival. Now it heals bottom up. And what I mean by that is, all of a sudden the survival brain, the wanting the 3 square meals a day, worrying about finances, worrying about, is my loved one going to allow me to come back home? Am I going to have a roof over my head? Am I going to be able to see my children? That survival brain comes back. And then the emotions come back, right? And the emotions come back before the ability to think clearly comes back. So the trouble with long-term sobriety is, I call it the emotional sobriety. Being able to identify what people are actually feeling, and being able to logically work through that and cope in a healthy way. And that's the challenge for long-term sobriety for most people. So what can I do about pause? We as trainers and champions, is how can we be more aware of things? And if we know or believe people are struggling, we don't have to say, hey, are you an addict? But we can start giving the forum for people to potentially talk about their anger, their stress, their anxiety, and things like that. Really identifying the emotional states that they're in, and being able to help them, so that way maybe they're not so impulsive or reactive. And people in early recovery, when they're in that post-acute, really those 6 to 24 months, they need that structure and daily routine. A job can really help with that if they add the other treatment things to that. Exercise can help reduce stress, really beginning to have patience and understanding and allow time to care for a big piece for a lot of people is that spiritual aspect, whether it's religion, spirituality, and things like that, because that can be a big coping skill for support. When people feel powerless for their thoughts or their emotions, a spiritual aspect certainly helps a lot of people. So last thing there is continued treatment. I touched upon this earlier. This is the director of alcohol abuse and alcoholism. You don't treat a chronic illness for 4 weeks and then send the patient to a support group. People with a chronic form of addiction need multimodal treatment that is individualized and offered continuously and intermittently for as long as they need. So what does that mean? I touched upon, right? It's if someone has a physical condition with a brain disease, with brain damage, that we have to treat physically. And some people just treat that with the detox. But as we know, the brain can be affected for up to 2 years. There's the mental, emotional part that we have to continue to treat. It's the here and now daily things that treatment certainly provides. A support group is very good. I am very active in a support group, right? With 12 steps and things like that. But that's a support group, right? So that's a great forum to really help with support, spirituality, guidance, perspective. But in addition to that, I'm talking about treatment in terms of a partial hospitalization program, an intensive outpatient, relapse prevention groups, individualized therapy to really help with this pandemic, right? I mean, we have COVID, but I like to say we've had this other pandemic called substance use disorder for decades now that is global, that we really need to learn how to treat in a healthier way. I'll give you another analogy of I gave the high blood pressure. If we look at diabetes, right? Certainly, there's signs and symptoms. Yeah, people say it's a silent killer, but people with diabetes will have urination retention or excessive urination, irritability, sweats, eventually diabetic coma, diabetic shock, neuropathy, and eventually needing to lose limbs. So there's all these signs and symptoms that we could certainly treat with a medication like insulin, right? For one form of diabetes. But the reality is some diabetics really struggle with eating their right meals so that way they don't have insulin spikes. So part of maybe the treatment could be or should be is, why is someone so resistant to changing their nutritional life? Why is that so challenging, right? And it could be, why is someone in denial that they're going to continue to not change their diet, nutrition, even though they could completely affect their life and kill them. So part of the treatment could also be support groups for them to really help them change that thought process and thinking, and continue follow-ups and checkups, because it's not just a one-time thing. Okay, you're in the hospital, you went into diabetic coma or diabetic shock. All right, you're done with it. Here's the things I'm going to tell you once, and I hope you do it right. You know, I think changing the model to really help people have a better way of life, physically, mentally, and emotionally, is so vitally important for whether it's diabetes, congestive heart failure, high blood pressure, and we're seeing this a lot with substance use. So this is a treatment on continuum. Detox is all in those 7 to 14 days. I say this says 3 to 5. Then we jump over here to support services. So I'm going to focus on detox, residential. I work at a residential facility. Our clients typically either detox here or come from a detox facility, either one, and we treat them at our residential facility for transitional for that 28 days up to 2 months. So we really help them. We do 3 individual sessions a week. So that way we help them with the family environment. One of those sessions is a family session. So that way we really talk about the family support, because one of the biggest stressors, 2 of the biggest stressors is typically work and home life. So if we don't bring in the family aspect, we feel that we're doing a disservice. So we have a family session once a week, and we also, every Saturday, we have family education, we provide education and interaction with both clients and family members. So we have up to 30 people with clients and family members having a conversation and perspective of how everyone is affected, because if you go back into that environment, that's one of your biggest stressors. So we really address that. And while we're at our residential facility, we believe that we're not just stabilizing them. That is detox, right? So detox is beginning to stable the body and the brain. And for, I think for any form of treatment, that there has to be some kind of functional recovery. So functional treatment equals functional sobriety. So one of it is abstinence, no longer using. Part of it is treatment, that we treat them with insight, education, philosophy. But the biggest piece for me is, while they're at our facility, is they're doing active things to think, to feel, and to react and cope in a different way while they're in our facility. Because if they can do it in our comfy four walls for 1 to 2 months and change the way they think and they feel and they react and how they communicate and other coping skills, then it's going to be a whole lot easier to do that when they step down into another form of treatment, like an outpatient or a relapse prevention group or a therapy. Any form of treatment, I feel, takes action, right? So the examples that I give for treatment, it's not just talking. Talking is just one piece of it to give them perspective and understanding. But if they do something different, then they will feel something different. If they do a different action, it is going to begin to change their brain and rewire their brain in a different way, because they're used to doing and thinking and feeling during their use the same way. And I'm asking them to change, and they're going to get really uncomfortable when they're at our facility. So when they're triggered and when they don't have coping skills and they want to use, they're in a very safe place to begin to do something different and take appropriate action. If people were just to detox for 3 to 5 days or 7 to 10 days and go right back to work, no wonder there's such a recidivist rate or a high relapse rate. We're not doing all the forms of treatment that are usually necessary. So it's not just insight, right? It's, if you do something different, you could feel something different. And that changes literally the neuroplasticity of the brain. Successful transition of patients from inpatient to outpatient is really abysmal. Part of the reason is lack of resources. You guys are all across the country, and there are probably some people in Canada and things like that, part of the issue is the amount of services that we have for people. That's a big issue. And the type of services aren't necessarily as good at one treatment facility as the next. So we understand that is also a problem. There's been some nice steps in the right direction. In 2008, the Mental Health and Addiction Parity Act now requires insurers to treat mental health like a physical health and group health plans. So now there's a whole lot more health plans there was the past 10 years and more, that there are more facilities to get help. This kind of sums up what I'm talking about. This is what I mean by holistic, right? It's sustainable recovery is treating every aspect of a person. If I don't help someone, we get people from out of the country, we get people from Hawaii, New Mexico, all across the country at our treatment facility, that if I don't help them with the correct referral services outside of this 1 to 2 month stay here at Tranquility Woods, I got to make sure that they continue to do an outpatient, an appropriate addictions counselor, help them with support groups like 12 Steps or Celebrate Recovery, which is a more religious-based support group, or Smart Recovery, to really begin to help them sustain their recovery while they go back into work, while they go back into their family lives with one of their biggest coping mechanisms gone. So I don't even know the time, but questions, thoughts?
Hey, Luke, Pat McCord from New York.
Hey,
Can you hear me?
I hear you.
Hey, Luke, how are you? Listen,
Well,
I've been doing this for a while. Just FYI, while I was on this call, I received a follow-up call from a member's wife who basically we were following on the streets for over a year. And every move she made, it was a deadly choice. But she would call because we have this program in place. And now we're trying to make sure that her transition, like you said, goes smoothly from, she's now in a partial program or an IOP with housing program.
Okay.
The problem, and also while I was in this call, I got a call from a psych services in New Jersey looking to join our in-house network of providers, which was good for me because I kind of needed it in the zip codes that they were in. So as you can see, we've transitioned not only from doing that, getting that member that dependent into treatment, but also finding the providers that we need in our area, like you said about sending back somebody to, you know, from coming from your facility to where they live. But two of the sticking points that I've come up with is the time frame. Most of our members need to return to work, and it's my job to make sure that they return to work safely. I would love to be able to keep a person in treatment, not only from detox to res to partial or IOP with housing to sober living, but from a financial perspective, they're already probably in danger or split up with their families, and they need to get back to work. So we've kind of instituted some more of the in-house peer counseling that we're doing right now here in the longer term. One of the other issues I have, and no disrespect to any of the treatment centers, is the Parity Act itself. A lot of the clinics that have opened have basically drained the funds when it comes to out-of-network, when it comes to substance abuse and mental health. And a lot of my work is to make sure that the funds that I work for doesn't get ripped off, but that we get everybody help. So in ending here, the member that we have, or the child that we have, the spouse that we have in treatment, is doing very well in a reasonably cost facility where we're monitoring that, and she can get as much treatment as she needs for as long as she absolutely needs. I think that's the goal that we need to get, where our funds are not depleted, but we can get as many people in treatment as we possibly can. I'd love to talk to you after this presentation.
Yeah, absolutely. And part of this in terms of, you know, the greater scheme of the IFTI and really every business within the EAP is finding those good facilities, right? That can do what you're talking about. And
well, it's funny. It's something that I've been doing now for 20 years, so I have a little experience with it. And it's not only that, it's those that will rip off the funds that really annoy me. You know, prior to the Parity Act, we couldn't get nobody into treatment. Now there's millions of treatment centers that are just looking for the business.
Yep.
So you have to do what you're doing, partnering up with a good institution, the IUPAT and Helping Hands. And that's probably one of the reasons why I want to talk to you after this.
Absolutely.
Thanks, Luke.
Yeah, absolutely. Thanks. Other thoughts, questions, perspectives? How does this, well, I'll leave that opening first and then I'll ask another question.
This is Dave Clifton from Seattle. As we were talking about the different programs and stuff, and I use my own personal experience with this because I've personally 15 years clean in June. But you know, I had my family support, but one of the things that I found was the hardest for me, and I had to leave an entire state to get clean, was, you know, I had the family support, but my friends, my acquaintances, my surroundings, I had to separate myself from all of that. And I think that was actually one of the hardest things for me to do. And it kind of, like I said, I had the family support, but, you know, the outside, my drug of choice was meth, and all my friends did it. And so that was probably one of my hardest things, was removing myself from all of that, because that was so much of all I knew was, you know, my friends, you know, my whole group. And to just literally pack up and walk away from it was, like I said, it was one of the hardest things. But once I did it, that was probably one of the biggest things that helped with my own personal recovery.
Mm-hmm. Mm-hmm.
I just wanted to throw that out there. It was just something that was kind of pulling on me.
Mm-hmm. Yeah, thanks, David. And you know, it's something that we see in a lot of facilities is sometimes it's absolutely not necessary or needed to go out of state, but sometimes it is in terms of getting the correct care and having, I'm guessing you, David, it sounds like you had a lot of, you may have presented with resistance, but it sounded like you had a unified front from your family to really encourage you to do so, which probably helped too.
Yes, it did.
Good. I guess one question I have for some of you guys and gals, what would be your takeaway in terms of what you see yourself taking in terms of training with what I gave you guys? What did I provide that you think would be beneficial for you to train other people that you will use moving forward that will help me in terms of what I need to tweak or if I was right on?
I think the biggest takeaway I got was the importance of longevity of treatment and how important that is, you know, to stay with the program, stay with treatment for the overall benefit.
Yeah, thanks, Josh. And one of the things we see when people all of a sudden, maybe a couple weeks in, or a couple, you know, maybe 2 months in, where people feel good, right? And they get those natural endorphins back and they think that maybe they don't need treatment anymore, right? So that's something to really look at and consider and continue to support. If things are good, let's stay on the track, right? Let's stay on pace and continue this process, because sometimes people call it the pink cloud, where people really feel good and, yeah, why would I want substances again? And people tend to fade away from their treatment in those first 3 months because they may start feeling better. And they haven't felt this way in a long time. All of a sudden they're sleeping again. Sometimes that doesn't come back. That's a sign of post-acute withdrawal as well, that it could take months for healthy sleep to come back. But if it does come back, people are like, why would I want a substance again? And one of the cunning, baffling, powerful parts of substance use is you don't have to have a desire to use to relapse, because that stress, that trigger can come out of nowhere, which is why that continuing treatment is so important, 3, 4, 5, even 6 months to longer because of that. So, thanks.
As I said earlier, Luke, when we were first beginning the conversations about getting the perspective of that person, that member that is actually going through it, and being able to recognize those signs and those triggers when you're having interface and you're having conversations with somebody, to recognize that something's not quite right, which can open up the opportunity to have a conversation. Obviously, there's some factors involved in that, and I think being a champion and recognized as a champion, we'll find ourselves in positions possibly where others will come forward and seek us out, and being prepared for that and knowing some of the complexities of what they're going through in their mind and how they try to rationalize their addiction. I think that can be very helpful to us. So.
Very well said, Mike. Yes.
I'd also say, just for those folks who don't believe it's a disease, how it does affect the brain from top down, like you said, and being maybe able to explain that better to those who don't believe or have a true understanding of how it does affect and the effects and how they go through the stages and scenarios with first the cortex and then so on and so forth. That's something to be able to be armed with, to be able to explain to family members or whatnot what's happening and what's going on, and how that help in detoxing will get them back on a better road.
Yeah, thanks, Lisa. And that's one of the reasons why, especially those first 3 to 6 months are so vital. It's because that intense feel good was there for so long. And that's part of the reason why progression happens. You have to use more to get that intense feel good. Now that is gone. And then those first 3 to 6 months acclimating back into their world, their work, can feel depressing, right? It's sometimes people go, man, I didn't get sober to feel this way. I don't want to be depressed. I don't want to be angry. I don't want to be frustrated. I don't want to be this stressed, right? So now we know, like Lisa, you're saying that there's a reason why that's happening, right? And it takes time for that brain chemistry and that logical brain and the ability to make sense out of that, yeah, you got a quick fix, you got a high, now you got to work to feel good. While you got to work to feel good, that brain has to come back before that can happen for some people. And I know Bob's going to also talk about that. I didn't even bring up if people are naturally depressed, right? People that have severe depression or an anxiety disorder that isn't substance abuse related, that's a double whammy, right? And then suicide can be an option for people. And Bob's going to talk wonderfully about, that aspect as well, in terms of how do we approach the mental health aspect, whether it's substance abuse related or not, that people need help and support during this time. How many people are depressed and anxiety because of the pandemic we've got going on? Our ability to connect in a way that we used to connect is gone and changed for an X amount of time. It's been at least 6 months. So we're seeing mental health go much higher. We're seeing substance abuse go through the roof because that maybe that we wouldn't have seen because of the times that we're in. So, one of the beauties of this form of holistic recovery is recovery and support may not look exactly the way it did, but that support is unbelievably there still. It's in the form of electronic meetings and phone calls and different modalities to help that so vital for so many people just on the mental health side as well. Got a little bit of time if we need it. If not, we'll pass on to Bob. But any other thoughts, comments? All right, thank you guys for letting me go.
I have a question for you.
Great.
Is it true that a person cannot get help until they actually reach rock bottom? And I mean, there's something to wanting to get clean and taking those steps, but until you really reach that point in your life, have you found that that's true for people? Or are there people that go in and dabble for a little while and they recognize that the road that they're going on is not a good way, and they stop before they get to that point?
I understand that way of thinking, but nowadays with the substances that are out there, some people don't have the luxury of a rock bottom. Some people can use opiates or heroin or fentanyl for the first time and they're dead, right? So the luxury of a rock bottom is not really non-existent or should be. It's ideally, I would want someone that says, I'm tired of this and I don't want to continue and I'm ready to get help, and they take all the suggestions, but how often does that happen? So we don't need to have people continue to suffer and feel that hurt without just reaching out a hand and being willing to offer some support or guidance or help when we see it as concerned coworkers or champions or family members, and we can help set up that condition. We can plant that seed, whether they're willing or not, that's one thing, but being able to provide an opportunity for change. I wouldn't want to see a coworker or one of my employees have to hit rock bottom before they get the help that they absolutely need, whether they see it or not. So no, I think part of the culture is changing just that. Hey, we're seeing some things, we can connect and we can sympathize and empathize, and maybe they're in a moment that they see that, and that's part of what we're doing here, and some of the other things that you guys are doing through the IFTI. So gosh.
Yeah, Luke, this is Pat again from New York.
There's only one rock bottom, and that's 6 feet under. So
Yep. I absolutely agree, Mike. It's not only opiates. You'd be surprised with alcohol and some of the other pills and stuff that's out there as well. Is that it takes you right through rock bottom, right through a death. Some of the things that we've done over the course of the past 20 years is just continue to push. So some patients, some members and their families might come into the MAT program in New York, not willing, but come in because they're pushed in by family, legal issues, job jeopardy issues. And we keep on pushing them into treatment. Hopefully they won't get to that point where rock bottom becomes their jail cell or their coffin. Now, I can tell you that we don't save everyone. I'm pretty sure that everybody's aware of that. We don't save everyone, but we make sure that that phone number or that phone is open for them once, twice, 3 times, so we can get them in. And maybe that second time or maybe that third time before they get to that rock bottom, they actually do what he was saying, is that they really want to change. So years ago, it was, wait for them. You know, it was more alcohol than anything else, cocaine. Now, the deadly mix puts them right into legal, financial, and worse, jeopardy.
Well said.
Thanks, Luke.
Yep. Thank you.
Okay. Luke, you do just a fantastic job, and every time I hear you, I learn more. And it's just, thank you for that. I'm Bob Swanson. Many of you know me. I was employed for 45 years in the painting industry. I was employed as a field painter, training instructor, and finally, my last 37 years, I worked as a supervisor, and my last 25, I was president of a company called Swanson Youngdale, a national painting and decorating firm, and now since my retirement, they are in the drywall business also. So I'm going to cover a lot of things in the next 45 or 50 minutes, but why I'm really with you today, I'm a suicide loss survivor. And what does that mean? It means my oldest son, Michael, at age 33, died by suicide on March 13th, 2009. So before I go any further, I want to make sure there's no harm in my comments. If my discussion brings up some things that are uncomfortable from the past, I would say mute yourself, and if you need to, get up and just get those thoughts out of your mind. This is not meant to be harmful to anyone. The second thing, if this was a class out in Hanover, I'd like to start by saying, think of your fellow employees, think of people in the neighborhood, think of family members, think of people you grew up with in school. How many of you have been touched by suicide? Meaning you know somebody that's died by suicide. And if I was in Hanover right now, I would submit we'd have almost 100% of you raise your hand. So basically, almost all of us have been touched by suicide at one point or another in our lives. The problem we have, we just don't know how to deal with it. And believe it or not, I was one of them for a long time. We had in the company an employee, her son died by suicide about 8 or 9 years before my son died. I had no idea what to do about that. So part of what I'm hoping by talking about a lot of topics today, you're going to get a little bit better understanding of what this all means. And believe me, a lot of this I've learned since my son's death. So it wasn't like I was this great expert prior to his death. And you might be saying, well, geez, he can't be that great expert. He lost his son to suicide. Well, I've learned a lot since then. So I'm going to cover some things. We're going to talk about mental illness, traits of mental illness. We're going to talk, biggest thing I'm going to talk about, looking at these issues with a different terminology. How we describe things affects how we think about it. We're going to talk about suicide statistics quickly, but the bigger issues, what's going on in our industry? And then what are we going to do about it? And this whole thing, Change the Culture, is what it's all about. So before I go any further, I've now used it a couple times, a term, my son died by suicide. And what do we normally say? He committed suicide. So I feel really strongly that that term, committed, blames the person. It also blames the family. Bob Swanson, what was your problem? You let your son die by suicide. You know, we'll talk about all this. It's an illness. He didn't want to die. He wanted his pain to end. His brain wasn't working properly. He looked at the world differently. So I would really submit, try it, and it takes a while, believe me, to try not to say the word committed suicide, but a person dies by suicide. They died from an illness that caused their death. Next slide. So, little different twist. Luke talked about what's an illness. This is kind of just a extension of that. It's a condition of being unhealthy in your body or mind. It's a specific condition that prevents your body or mind from working normally. All illnesses, including mental illnesses, are treatable. It's nobody's fault. Nobody wants these illnesses. Mental illnesses are illnesses of the brain. Next slide. So, I want you to think, there's a lot of similarities between physical and mental illnesses we don't normally think about. They're difficult to diagnose. Mental illnesses are difficult to diagnose along with physical. Our son was an exceptional, gifted person, great energy, athletic, likable. Everybody loved the guy. But as we look back, now I'm a little smarter, in about 9th grade, he started changing. And he was misdiagnosed with clinical depression. It's very common within adolescence to have a misdiagnosis. Why? Our brains don't fully develop until mid to late 20s. So until he had his first attempt on his life at age 29, he was misdiagnosed. His therapy was not the right therapy, and his medications were not the right medications. It took an attempt on his life to finally be diagnosed that he was living with bipolar disorder. Co-occurring. Luke mentioned dual diagnosis. The fact that my son had many illnesses, but 2 of them were bipolar disorder and the substance use disorder with alcohol. Range of severity. People can live with these illnesses and just work fine. But there's a range of severity, just like all physical illnesses. So let's just take an example. Anxiety disorder. It may be very mild, and with self-talk therapy, medication, that person performs well every day. The flip side, near the end of my son's life, his anxiety disorder was off the charts, to the point he was afraid to leave his home. So he was homebound, he was paralyzed, unable to leave his home. Then we have side effects from all drugs. So let me talk about that for a minute. The common thing, as you look, any of us take any medication, which at my age, I take some medication for various ailments. If you read all the side effects, you don't even want to take it. But a person with either a mental illness or physical illness, if there's something's prescribed and it makes you feel worse, what do? We quit taking it. And if we still feel crappy, we might self-medicate. That's exactly what my son did. He was using many medications and they had extreme side effects. The flip side, and Luke talked about this. If I'm taking something, and last year I had a major infection on one of my feet. I was prescribed a very heavy antibiotic, and I was told, take this twice a day for 14 days. Well, you know what? After about 5 or 6 days, the swelling was down, the pain was almost gone, and it was easy to say, I don't need that anymore. But I thankfully kept taking it. Oftentimes, what do we do as people? When we start feeling better, we quit taking it. And with the use of antibiotics, it's very common. Then there's relapses. Luke talked about relapses with substance use disorder. There's relapses with physical and mental illnesses. There's no straight line for any illness that I know of. There's ups and downs. So what are the two most common physical or mental illnesses? It's anxiety disorder and depression. Anxiety disorder is different than being anxious. Anxious, you're just a little uptight. Prior to, in the painting business, from the office, putting in a bid, are we going to get the bid? Did we do it right? That type of thing. First day on a new job, we often have felt that, but it goes away. Anxiety disorder is that feeling of nervousness, helplessness, a sense of danger, doom, increased heart rate, trouble concentrating, trouble sleeping. Those are some of it's much deeper. Depression, it's more than just being sad. It's way inside. It's a feeling of worthlessness. It's a feeling of hopelessness, a feeling of dread. So about 20% of all adults in our country are living with a mental illness. About 10% are living with substance use disorder. And as Luke said, and I have said many times, they're co-occurring. So this impacts not only families, it impacts, or not only workers, but their families. So we're going to talk about some of that. Okay, next slide. So a big question, why do we react differently to someone who has a physical illness versus a mental illness? Well, I think a big factor, we can't see what's going on inside a person. So if my son was right on the slide right now, and sometimes I show his a picture taken only months before his death, he was in horrible pain. He has a big smile. Nothing's wrong with him. He looks fine. He'd tell you he looks fine. He'd tell you he's fine. It's all a mask. So anyone living with a mental illness wears a mask until you build confidence, trust, and start working at what's really going on inside. So you can't judge the person by what you see on the outside. Now I want to talk about a little bit terminology again. So how do we treat someone with a physical illness versus mental? Okay, mental illness, typically we say, he's bipolar, he's an alcoholic, he's schizophrenic. Very negative, demeaning terms. They're labels. We're labeling the person with the illness. We're basically saying it's your damn fault. Not true. Versus physical illnesses, we'll say, we don't say person lives with cancer. We say, or person is cancer. They live with cancer. So again, try that terminology. A person's living with these illnesses. They're not bipolar. They're living with bipolar disorder. Next slide. So these are common traits of anyone living with a mental illness. There's usually more than one. My son had 4. And these weren't, of course, all discovered all at once. He lived with bipolar disorder. He lived with an illness called seasonal affective disorder. In the northern climates, this happens in the winter. Again, remember, these are all chemical imbalance in the brain. In the winter, lack of sunlight, he happened to need that sunlight to get his serotonin going. And we finally noticed this when he was in college. He did exceptional freshman year in the first semester. The second semester, he did horrible. In fact, I got a call from the dean that they were going to kick him out of school. Wasn't attending class. Well, his motor wasn't running. What do I mean by that? Think of it in terms of a spark plug on any gas motor. If you take that spark plug off, it will never get going. So another thing we tend to say about people with mental illnesses, they're just lazy. My son wasn't lazy. Nobody worked harder at trying to just get through a day. His spark plug, his chemicals in his brain weren't allowing things to work properly. Regular use of alcohol or drugs, very common. And now we know regular use of tobacco. My son did all three. Lots of anger. And I mean, it just comes out of nowhere. Unfortunately, I took that anger personally, and sometimes my son and myself, we didn't have very good discussions. He wasn't angry at me. Shame on me for taking it personally. It wasn't about me. He was angry at his illness. Why can't I get better? I'm doing everything I'm supposed to, and I'm not getting better. Then shame. Have you ever heard of any illness a person's ashamed of? My brother had and died from a form of cancer. He wasn't ashamed. Everybody knew he was living with cancer. We supported him. We were compassionate towards him. My son was ashamed of his illness. We were ashamed of his illness. And because of that, we didn't tell anybody. The only people that knew about my son's difficulties were basically our kids, our immediate parents, and that was it. Friends, they had no clue. Distant relatives, no clue. We were ashamed. Then you have questionable decision making. So all I can say with this, I like to use the term, my son had a dirty windshield. So what do I mean by that? So in the northern climates, especially in Minnesota, we pour sand and salt on the roads in the winter so that people don't drive off the roads. And then that kind of creates a slimy mixture. And when you're driving, it gets a slimy mixture on your windshield. And then when you hit the windshield wipers, it smears. You can't see. And if you don't have any windshield washer fluid, you're in trouble because you can't see. Well, I'd like to say my son's windshield was dirty. He didn't see clearly. So if you don't see clearly and your brain isn't working properly, you make some really bad decisions. And he made plenty of them. And I've made quite a few myself. Prescription medications. I talked a little bit about that, the ability to quit taking drugs because of all the side effects, or you quit taking them because you feel better. Another thing about prescription drugs for mental illness, because again, it's working on our brains, it takes about 8 to 10 weeks for a new drug to really have full effect on our brains. So he'd go to his psychiatrist, and maybe the drug he was using wasn't effective, so he'd get a new one. Can you imagine waiting that long to see if it's improving, and that the whole time it's giving you side effects? You got to be pretty darn persistent to hang in there. So I have lots of empathy today. I didn't at the time. That, my goodness, it's no doubt he gave up on some of this stuff. Next slide. So the good news is most people living with a mental illness live in recovery. Again, they're walking around among us every day. So, but more should be living in recovery. And why aren't more? Only about 60% of the people living with a mental illness get the treatment they need. Part of it's the shame. How am I going to tell anybody at work I got to take a day off to go see a psychiatrist? Or how many people are going to say, geez, what happened to you the last 3 or 4 days? Well, I had to put myself in a mental health unit. That doesn't fly very well. So the shame, the stigma keeps people from even getting treatment. And then we have a total lack of adequate mental health facilities in this country. total lack of psychiatrists, total lack of psychologists. So give you an example. If today I called a psychiatrist and I had never been on one of their patients, I could well wait 8 to 10 weeks to get an appointment. Now, if I was having a crisis, how can I wait 8 to 10 weeks? If I today was having a crisis with my heart or any other part of my body, I would get in to see a doctor without question. Then you might say, well, you know, hospitals will take you in. Well, let me tell you a story there. After a while, this was after my son's attempt, I got closer to him and I started figuring out things. And a question I'd ask, like you get asked when you go see a doctor, what's your pain level today? And this was a day he said, Dad, my pain level's out of sight. I said, well, do you think we should go down to the hospital? He had been hospitalized up to this point twice in a mental health unit. And I said, do you think we should go back to that? He said, yeah, let's go. We waited 8 hours in an emergency room for him to get assessed and then finally get admitted. At this point, he was in crisis, believe me. And then you are not put in a normal place where in the emergency room they have just cloth curtains. We were put in a sterile room, metal walls, wired glass, with a chair for him and a chair for me. It was the most overwhelming experience I've had in my life. I used every trick in the book to keep him in that room. Now, if I had gone to that hospital and said, I'm having chest pains, I would be admitted immediately. But I have to think they had a lack of beds. They had a lack of doctors to do an assessment. So, and then because our son was very smart, once he did go in for treatment after his second attempt, he knew how to work the system. And unfortunately, and probably Luke can speak to this too, with lack of beds, there's pressure to kind of triage, well, this person's better, we need to get somebody really needing help. So my son figured out how to work the system. When he got checked out his last time, that was about 3 months before he died. He was not well, and it really still bothers me that he got out, but I'm sure he convinced people he was well. He was a good actor. Next, some people living in recovery. One I'll just mention, Terry Bradshaw. If we were playing NFL football, which who knows if we're going to, he does NFL today. Terry Bradshaw has an illness. He lives with bipolar disorder. You would never know it. He's living in recovery and probably in getting the treatment he needs and the support he needs. Next slide. So this big thing I mentioned, people wear a mask. When you see that person living with one of these illnesses, that's what they look like. All you see is the tip of the iceberg. So remember that, please. Next slide. So I don't want you to think just because you have a mental illness, you're going to die by suicide. That's not the case. But most people that die by suicide, a high percentage, live with a mental illness or substance use disorder or both. So in 2019, here's the statistics: 47,173 suicide deaths. It's the 10th leading cause of death. Here's one that really impacts our workforce. Among males 25 to 54, it's the second leading cause of death. Another one that affects our workforce, 78% of all suicide deaths are males. Suicide deaths are up 33% since 2019. Since 1999. And in 2019, there were an estimated 1.4 million suicide attempts. So not only did we lose in 2019 over 47,000 adults, 47,000 people in the United States, we also had 1.4 million attempts. So think of the impact on our society, impact on families. I can tell you losing a son to suicide that will impact myself, my wife, and our entire family forever. His attempts, the other thing very puzzling about the attempts, we didn't tell anybody. And you go, what? I was ashamed. I was scared. Likewise was he. Again, I'm not going to tell anybody. Our son tried to end his life. So think of how lonely that is. And he had the same shame. So it's horrible. It's a horrible situation that we have to start talking about these things. Next slide. Okay, we have a crisis not only nationally, we have a crisis in our industry. We like to be number one, but this is something we shouldn't be number one in. We have, in our construction industry, more suicides than any other industry. Our suicide rate is nearly 4 times the average for the whole rest of the population. Why do we have that? Whole bunch of reasons. And this is, so what you see on the screen is the culture we have, and what we need is to build a new culture. So old school tough guy culture. That applies to females and males. I just use that in a generic tough guy culture. Why is that? Well, here's what my opinion on that. We're a service industry. We're a tough, every day is game day. There's no slough day. We have tough schedules to meet. We have high quality standards to meet. We're a service industry. And we have to perform every day. So if you're dealing with some physical, mental issues, are you going to tell the coach, I can't perform today? You might be off the team. You waited all winter to get on the team. There's no way you're going to tell the coach, that, meaning the foreman or the owner, I can't do it today. So you tough it out. You suck it up. All those things that have been built into our culture. We go where the work is. We do the work when it's there. What does that mean? Well, a customer wants, I can tell you as an owner, a customer wants us to do a project second shift, third shift, weekends. There's a holiday shutdown. We never said no. And our employees never said no. We got to take care of a customer. There's sleep disruption. Not only sleep disruption, that person is away from their family. They're away from their support system. Then we go where the work is at traveling. I was a road guy, and I can tell you it's lonely. It's not fun. And you've got those same issues, a lot of temptations. Then we're a physical industry. You spray for 30 years, you hold a blast nozzle for 30 years, you lay carpet for 30 years. I don't care what part of our industry. There's physical pain that builds over time. Those muscles, those joints get tired. So you start with maybe over the counter. Then you go to a prescription drug. And in the meantime, those aren't really working too well, and there's lots of side effects, so you self-medicate. And unfortunately, self-medicating is not looked disfavorably in our industry. It's kind of encouraged. And I don't think I'm speaking out of turn there. So then we have seasonal and end of project layoffs, which cause tremendous financial stress. And it's one of the worst parts of our industry. There's no guarantees you're going to work all year. Project ends. Many times I had to be the bearer of bad news and say, hey, the project's over. We don't have any work to replace all of you to a different project, and I'm sorry, I got to let you go. No fault of the person. In our climate, come November, weather changes. We can't paint outside. About 25% of our crew got laid off every year. It's lousy, but it's just no fault of anybody. And then there's access to lethal means. We're an outdoor industry. High percentage of our people in this industry have access to firearms. They're hunters. And that is partly why the male suicides make up 78% of the suicides. Another key point, so why all these things disrupt, A person living with a mental illness not only needs their therapy plan continued, but they need balance, diet, sleep, exercise. We could tell when our son was out of sync, so to speak, his behavior changed. Again, remember that chemical imbalance. Next slide. So there's a lot of myths about suicide. First, remember, all mental illnesses are treatable. All suicides are preventable. Those who talk about it won't do it. Totally false. If they're talking about it, they're thinking about it. Talking to somebody about suicide might put the idea in their head. Again, if you ask somebody, are you having suicidal thoughts? If you feel that inside of you, they're way ahead of you. They're already thinking about it. Suicide attempts are just a cry for attention. Totally false. They're crying for help. They're not crying for attention. They're in desperate need of help. Once a person has a suicidal plan, they cannot be stopped. Totally false. So let's talk about any action we take as a human being. There's three general points to any action we take. There's the idea, or what we call ideation. There's plan, and then action. At any point in there prior to the action, there can be a stop. Let's stop, look, and listen to where we're going here. There's been studies analyzing people that have survived a suicide attempt. And what's come out is over 50% of those that have survived the suicide attempt, that whole progression, idea to plan to action, was an hour or less. So many times, this is not something pondered for weeks and months. It's something triggered it. Remember, they have a dirty windshield, and boom, they take the action. So what are some clues? Next slide. All clues take seriously. They're not for fun. They're not to get attention. They're crying for help. So think about this. Because of the shame, a person contemplating suicide is not going to say, I am thinking today of killing myself. I got a plan and I'm ready to take action. There's so much shame over that to even be thinking that. They're not going to say it that way. So these clues, you have to really look through them. Remember, look through the mask. Verbal clues. I wish, these are just examples. I wish I were dead. I'm tired of life. I'm a burden to everyone. Soon you won't have to worry about me. Huge in this is being a burden, losing hope. Remember that hopelessness, that dread? This is all wired in to those clues. Next slide. You'll have to go one more. There we go. So there's also behavioral clues. Behavior's changing. They're withdrawing from family and friends. They're really moody, hopelessness, and unexplained anger. Boy, those are huge. Putting personal affairs in order, giving away prized possessions, acquiring a gun, or stockpiling pills. Again, my son had 2 attempts. I wish I had known some of these things, but I didn't. So that's partly why I'm telling you today. These are just clues that are something, the behavior has changed and what's really going on inside. Next slide. There's situational clues, okay? Loss of a job, it's huge. Loss of a major relationship, that's huge. Diagnosis of a terminal illness. Loss of a family member or friend by suicide. Arrest and loss of freedom. So built in those are losing hope, shame, and losing control of your life. My gosh, my relationship just went out the window. I lost my job and I didn't do anything wrong. I did everything I was supposed to. And I got arrested for a DWI. So how important is this? Centers for Disease Control in 2015 studied all suicide deaths. 29% of those deaths occurred within 2 weeks of a life-changing event. Within 2 weeks. So think about those that are up on the screen. When we talk about people that and visit with them, they've lost a major relationship. Well, they'll get over it. They just lost their job. They come in the union hall looking for work. Well, they'll get over it. Think of the impact that has on their core. And then think of if they're not thinking clearly, they have a brain illness, what might they do? We have to be sensitive to that. Next slide. So I want you to consider, as you're talking with a student that is having all those things we've talked about, not showing up to class, bad attitude, moody, nobody even wants to be around them anymore, or that person that got laid off comes in the union hall with kind of the same type of demeanor. We need to assess how serious is the situation. So I like to put this in terms of like a physical injury. Again, we can't see it, but a physical injury, is this first aid where it's just a cut on the finger? Or is this, they just lost a limb and we got to call 911? You need to be thinking in those terms. Meet with the person alone. The shame is overwhelming. So you need to meet with that person alone. Convey your concern. Here's what I've been hearing you say lately. Here's what I've been seeing. And I know you just lost your job. We talk about it. Tell me what's going on. Listen, no judgment. Cloudy windshield, they're going to say some things that make no sense. You'll shut it all down if you say, you know, you got plenty to live for. You got 2 kids, you got a wife, you got a home. At this point, if they're having suicidal thoughts, none of that means anything. Listen, stay with them. If they're really at a point, it's more than that first aid issue, you're really concerned that they've already got the idea and they maybe putting a plan in place. Are there any lethal means nearby? And then, hey, I'm here for you. I want you to be back on the A team. I want you to do well. Can we call somebody to get some help? I'm not an expert at all this, but I'm here for you. Let's call somebody. That might be in your EAP program. It might be a crisis line in your community. And then have resources available. At the last slide, there's some resources, but a couple key ones. The suicide prevention line, it's staffed, and this unfortunately is US. I don't have in front of me the Canadian one, but the US one is 800-273-8255. And if you text, it's home 741-741. If it's a crisis where you'd call 911, ask for at least again in the United States, ask for a CIT team. That's a crisis intervention team. They've been trained how to handle a mental health crisis. And thankfully in my state, police officers are more and more required to take that training. I have helped conduct a few of those classes, just the portion on mental health and suicide prevention. So they're very effective. Next slide. So I want you to know you can make a difference. You've seen some clues. You're concerned about that person. How can you make a difference? Let me just give you one quick example. I did pretty lengthy training for the company I retired from shortly after I retired. And about 6 months later, a very good employee sent a text to one of the supervisors, and the text said, I can't do it anymore. And that supervisor thought, you know, that doesn't make sense. I'm concerned about this. Made that number uno priority, got his supervisor, and the two of them took about an hour to finally make contact with that employee. We're here for you. We're concerned about you. Can we come and meet with you? Where are you? The person finally opened up. I'm in a parking lot. I'm in a park, and told him where he was. When they got there, he had the idea, he had the plan, and he had the means to end his life. Thankfully, they took immediate action, got him the help he needed. And the good news is, one, they saved a life. And number two, he's still a valuable employee and a valuable member of the IUPAT. But had that normal reaction might have been, I'm really busy today and I don't have time to deal with this crap. And if the guy can't show up to work, he's down the road. We would have lost a life. So I want to use the next slide. We create a different culture. Wellness and what we're doing with Helping Hands, and that's partly why I'm involved in all this. It's a great program. We're going to make wellness a priority. It's openness, support, training skills, seeking resources. Here's the key. We got to treat physical wellness the same as mental wellness. This is safety and health of all team members and all employees. It's their safety and health. So a couple quick things. One, I would submit with physical injuries and physical health, we're really good at light duty return to work. If I've gone in and had back surgery, whatever, whether it was work related or not, what do? Well, we got Joe back and he can only have a 50-pound weight limit. So we're going to kind of, let's face it, we're all going to kind of put him, I'm as an employer going to put him in a job where he doesn't have any lifting. I'm going to tell the crew, hey, Joe's back and let's just kind of lay low on him lifting things. We get him back to where he needs to be. Somebody goes to Luke's facility for a month and they come back day one. Remember, they look fine, look good, no restrictions. That person's right back on the battle line. And all of a sudden, the day two, they're not up to it. They're not really putting out. And we say, well, yeah, I guess we got to let that person go. There's no light duty for that person that comes back with a mental issue, something that is struggling with. We need to treat them similarly, treat them the same, actually. So let me talk about old Bob, new Bob, the next few minutes here. I lived the culture we've had in the past. Believe me, I was that guy, unfortunately, part of my job. Somebody wasn't performing. Somebody wasn't showing up to work. And you as training directors have done it too, because when I was with training, I did it also, but also as an employer. You know what? I don't know what your problem is. If you don't get your act together, I'm going to have to cut you loose. Done, right? And nothing changed. Down the road, never thought twice about it. New Bob goes, you know, there's something going on here. And this person's was a good employee. They've been struggling lately. I want to find out what's going on. I'm going to go talk to that person one-on-one and just say, you know, I'm really concerned about you. You've been a great employee, but things have changed. There's something going on at home. There's something going on with you. If you don't want to talk to me, let's call our EAP program. You can talk to a consultant or a third party and I'll have nothing to do with it. If you need some time off to deal with something at home, let's work this out. I want you to succeed. I don't want to lose you. Wow, what a difference. And then old Bob, new Bob. And I would submit you as union reps aren't much different than me as an employer. A union rep, you get a call from Bob Swanson. I need 2 people to work in Tulsa, Oklahoma for a month. Who do you have? If it's a hiring hall, you give me the next 2 on the list. If it's not a hiring hall, you'd give me who's been bugging you for a job. Did you ask that person if they can work 612s? Did you ask them if, other than what skills, if they can hold a blast nozzle and we're blasting, then you send them that job, right? It's real simple. Well, it's on the same hand, I was doing the same thing. Hey, I got this job in Tulsa, Oklahoma. We need you as a blaster, and I'll expect you for the next month. I'll get you a vehicle, a gas card. We'll pay you a sub, and I'll see you in the office on Monday to load you up. Same thing. Anywhere there did we say, is this going to impact you or your family? So what happened on that job, and actually it was in New Orleans, we sent a guy just like that, and within about a month, the whole job fell apart. I get a call from the customer. Your guy hasn't shown up all week. I go, what the heck's going on? I finally track him down. I didn't know he had a substance use issue. Never asked him Guess what? He was away from his support system. He's on the road. He was working 612s, all the worst things in the world. Later, another time, a couple of years later, I was smarter. And I actually asked the person before sending him out of town, is this going to cause a problem? And you have permission to say no, that it's not going to work. I allowed that person to do that. Guess what? A year later, they did agree to go on that same project. It was a 3-year project because things had settled down in their home life. That's a win-win versus lose-lose. So we all have that capability to do this different, do this smarter. So last slide's got some resources, and then I know I'm out of time. I just want to end with, 1, thank you for allowing me to do this. 2, having lost a son to suicide, I was held guilt. I'm a male that was trained to provide and protect my family. I couldn't do that. And I felt a lot of guilt, a lot of anger. And my faith has allowed me to get to where I've been the last 5 years. This is part of my healing. And I thank you for letting me tell a story of our family, and also hopefully you can use these resources and what I've stated for helping others. Thank you.
Thank you, Bob. And thank you, Luke. We're extremely fortunate to have you both with us today and provide us with this greater understanding of substance use disorder, suicide, and mental health through your own personal experiences. It's extremely powerful, and we are very thankful that you're a part of the Helping Hand team and a part of Changing the Culture of Construction. Having the perspective of these complexities that someone with mental health issues is experiencing gives us the compassion and patience needed to see them through these experiences that they face on a daily basis, as Bob had mentioned. Changing the Culture of Construction is our greatest foundational tool to provide the members education in substance use disorder, suicide prevention, and mental health issues. The educational components of Changing the Culture of Construction on the LMS provides us with that foundation on which we build the Helping Hands initiative and the future, and for the future, and provide IUPAT members with the tools that they need to get the help and the resources to, when that time comes, we have those for them to utilize. And I'm asking you today, if you have not already done so, begin the process of training the Changing the Culture of Construction in the training centers. Talk to the DOT. In our meetings, we are in that stage where we're building our Helping Hand teams. And these conversations are extremely important, as you can see in hearing from Bob and Luke today, as we move this forward, bringing those alongside of us to support the Helping Hand initiative. A year ago, we had just completed the IUPAT 32nd General Convention in Las Vegas, where GP Rigmaiden spoke very passionately about the IUPAT Helping Hands and Resolution 12, that no IUPAT member would be left behind for support in substance use disorder, suicide prevention, and mental health issues. And I'd like to read that to you if I can, just as a reminder. And I think a lot of the things that we've talked about today really puts this in perspective. This has come a long way from 2017 when we first began to build this. But that the resolution states, whereas the suicide rate for construction workers is the highest among all industries in the United States and Canada, and whereas suicide and substance use abuse overdose rate for IUPAT members is approximately 10%, and whereas studies report that 15% of construction workers suffer from substance use disorder, and whereas these heartbreaking issues are sure to have an affect the families of every single one of us sitting in this delegation today, and whereas we as leaders of our union, have the duty and responsibility to protect our fellow brothers and sisters by providing the materials and resources for help. Therefore, be it resolved that every IUPAT district council implement the IUPAT Helping Hand and Changing the Culture of Construction programs within the next 5 years. We've had these conversations in our meetings, and Bob and I personally have talked about, wow, 5 years. Do you think we can have that done in 5 years? But here we are 1 year later, one crazy year later, with COVID-19 and everything that we're facing throughout the world. There's too many challenges to even list, but here we are moving it forward. Helping Hand champions have been named for all IUPAT district councils in Canada, the Western, Central, and Eastern regions. We've engaged in Zoom conference call meetings, and we're well on the way to building those Helping Hand teams in every district council. We found that we can and will present Changing the Culture of Construction through webinars, as we've done today. This session is our third since April. And we are coming together because why? Well, as we learned in our session, in our convention in Las Vegas, we are union. We see a need and we fill the need. Some of you have heard me talk about what Helping Hand would look like in 10, 20, and 30 years. Those of us that are champions of the Helping Hand Initiative have a vision as to what this will look like as a successful IUPAT program. So the stigma of a brother or sister coming forward and saying that I need help, that's removed. Substance use disorder, substantially decreased, if not eliminated altogether. Suicide, substantially decreased, if not eliminated altogether. Mental health and wellness restored to member brothers, sisters, and their families. Life saved, hope regained. That's what we're looking for with the Helping Hand Initiative. Lives saved, hope regained. And this week, we continue to work and look forward to the Eastern Region meeting on Wednesday. On Thursday, the Canadian team, champion team, will meet together in the Western Region on Friday. So we're meeting on a regular basis. The meetings have just been going very well as all district councils and you as champions are building your teams and moving this forward. Again, what's it going to look like in 10, 20, 30 years? I believe our vision is that it would be a program that's been sustainable from the work and the foundation that we're building right now. So I want to thank you all for your commitment to be here today, your commitment as champions, and moving the 10 steps of implementation plan through all of our councils in North America. And when we've implemented this 10 steps of implementation, we know that we're in position to provide our members the consistent support and resources. And we'll be able to do that when they need it most. And that's immediately. So I really want to thank Bob and Luke again for their presentations, the staff at IFTI in pulling this all together. We'll do another in the future. I'm positive of that. And I look forward to seeing you all in our champion meetings. And I'd like to open it up for any discussion that anybody has right now. And then at that point, we'll turn it back over to IFTI. Anybody have anything they'd like to bring up? All right, crickets.
All right, well, thank you, Mike. Thank you, everyone. If you do have anything for Bob or Mike at the time, speak now or forever hold your peace. No, I'm just kidding. Feel free to email us at the FTI International if you do have any follow-up questions. Here are the resources for any sort of Helping Hand information that we have here. Here's Mike's information. Here's the IUPAT Hub's information. So if you guys do have any questions or concerns, certainly reach out to us. But this kind of sums everything up. Please don't forget, for those of you who have actually taken the prereq course and have already done the pre-work online, to get credit for today's webinar, you must go ahead and sign into your LMS account and then do the Changing the Culture of Construction survey. So it's going to be based, the survey is going to be based on today's presentation, the supplement to the online training that you all had completed. So just a few reminders from us there. But again, if you get stuck, you can certainly email us at ftiinternational.org if you have any questions or concerns. All right, with that, I want to thank everybody. Thank you, Luke. Thank you, Bob. Thank you, Mike. Thank you to all of our students and participants today. Without you guys, we wouldn't have been able to provide this course. So just want to say thank you, everybody. Please stay safe. And you let us know if you need anything, okay?
Thank you.
Thanks very much. Appreciate it.
Thanks, everyone. See y'all soon.
Thanks, Luke. Thanks, Bob. Thanks, Mike.
Take care, everyone.
Thanks, everybody.